Second is your mitral valve disease. There's, like yesterday we were discussing, if it is mitral stenosis or mitral regurgitation also. In mitral stenosis, the left ventricle failure will not set in first. It will come to right ventricle, as yesterday we told you, right ventricle, and ultimately the whole biventricular failure settles in. But in MR, mitral regurgitation, because the blood going in reverse direction, and while coming, it comes with a more volume, then there will be left ventricular enlargement, hypertrophy, then causing heart failure. Then again, the next site is your left ventricle. Left ventricle is damaged because of cardiomyopathy, dilated cardiomyopathy, or any cardiomyopathies, or if there's an ischemic heart disease, the left ventricle may be responsible for the heart failure. So it could be disease in the left atrium, it could be disease in the mitral wall, it could be disease in the left ventricle to cause the left-sided heart failure. Now coming to right-sided, same thing here. If there's any defect in the left atrium or your tricuspid wall or your, aortic valve also. If there's an aortic valve stenosis, when left ventricle is not able to pump the blood out enough, your left ventricle fails. So the heart LVF. So disease can be in left atrium, left ventricle, mitral valve, or aortic valve. This is aortic valve. It's not here. I'm just writing here. It will be somewhere here. Same thing here. If you come to the right side, the disease can be in your left atrium or a tricuspid valve or right ventricle itself. If the right ventricle is damaged because of the cardiomyopathy or ischemic heart disease, the right ventricle is not able to pump. Then your pulmonary artery. If the pulmonary artery is diseased, pulmonary regurgitation, you get right ventricular failure. Ultimately, whether it's the right ventricle or left ventricle, after some time, there will be biventricular failure. This is RVF. So this is the rough mechanism that for you. This is enough. If you have any questions, we can take up in the end. So as I said, there's diastolic heart failure, systolic heart failure, and high output failure, low output failure. How do you know diastolic or systolic? Because all these failures, all these terminologies, diastolic, systolic, high output, patient will come with breathlessness, chest pain, palpitation, syncope. These are the typical symptoms of heart failure: tiredness, weakness, loss of appetite, sweating, breathlessness, chest pain, palpitation. These are the speed edema, ascites. These are the signs and symptoms that any patient of heart failure will come, irrespective of the etiology. And you also have acute and chronic heart failure, as I told you. So what are the other tests? It's the signs and symptoms are, if it is acute, the patient will come with sudden breathlessness, what we call it as a flash pulmonary edema. Flash pulmonary edema means sudden acute left ventricular failure. It can occur in acute MI setting, previously healthy normal patient. So sudden breathlessness, they will be pallor, they will be clammy hands, and pulse will be rapid, as I told you, and the peripherals, the hands and feet will be very cold to touch, and patient will also have orthopnea. Orthopnea means patient will have breathlessness. Orthopnea is a little advanced stage. Patient will have exertional breathlessness, but when you make them lie down, when they're lying down, the suddenly breathlessness increases, and when they're sitting and stooping forward, breathlessness comes down. That's why we have every patient, we have a small table, what we call it a cardiac table. Usually we used to write the notes. Actually, that is actually the cardiac table. It goes inside the patient's cot, and patient can bend down and put hands like that. This position gives the patient relief. That's why this is called a cardiac table that we use. Every hospital has this table before the patient's cot. So that is orthopnea. Orthopnea is little bit severe grade of breathlessness, and you can see the JVP will be raised, especially when okay. JVP is raised, and because of the peripheral pooling of the blood, peripheral congestion, you have ascites, you have speed edema. So these are the features. And if you auscultate, on auscultation, what will you have, patients? You auscultate in the heart, you may find a triple rhythm. Triple rhythm is something, your heartbeat is like this. But here in heart failure patients, they will have tachycardia. And sometimes we have triple rhythm. Triple rhythm means the three. Something like that. This is called triple rhythm or gallop rhythm. Gallop is horse's gallop. So it could be S3 or S4. S4 gallop or S3 gallop depends on the severity of the left ventricle. So on auscultation, you may find a tachycardia, you may find a gallop rhythm, you may find JVP elevated. Sometimes you may find a murmur. I'll tell you why murmur. Suppose, for example, there's a aortic stenosis here, and the blood from the left ventricle is not able to get emptied completely, so the left ventricle becomes enlarged. When left ventricle becomes enlarged, even the mitral ring also gets enlarged. You get a functional murmur of mitral regurgitation, functional murmur. So in heart failure patient, you may get if it is left heart failure patient, you will get a functional MR murmur, mitral regurgitation murmur. Here, the valve is not defective, valve is innocent, but only because of the dilatation of the left ventricle, the mitral valve ring also gets dilated, and it gives way to the left ventricle blood to go up and causing mitral regurgitation. Same thing happens here. Same thing happens here on the right side also. So when the right ventricle is enlarged, so the right ventricle, the tricuspid valve ring gets widened, and you get tricuspid regurgitation. You may also find a TR murmur. So you may find a MR murmur, you may find a TR murmur. These murmurs are functional murmur because the valves are not defective. It is only because of chamber enlargement you are finding these regurgitant murmurs on auscultation of a heart failure patient. And as I said, triple rhythm. That is a triple rhythm you can hear. Then these are the murmurs you can hear, and JVP will be elevated. If you palpate the abdomen, you may find a tender hepatomegaly, and sometimes patient may have, because of the peripheral congestion, you may find ascites or pitting type of pedal edema. So these are the clinical signs and symptoms of heart failure. And if you test these, the blood test, biochemical test, when you do, you may find that there's some electrolyte imbalance in the form of hypokalemia or hyperkalemia, hyponatremia, because in heart failure, there will be volume overload, hemodilution. So this is called dilutional hyponatremia. The sodium levels may be low, and that could itself cause some separate complications. Hyponatremia, this is dilutional hyponatremia that can cause secondary separate complication. And your kidney also may get involved, what we call cardiorenal syndrome. Your creatinine may get elevated because, after all, kidney is not getting enough blood supply. Ischemia to the kidney will push the kidney down into AKI, acute kidney injury. So you call it as a cardiorenal syndrome. And same thing can happen with your liver, because liver also is getting backlogged, because with backflow, the liver gets congested, and liver parameters like SGPT, SGOT, they may get elevated.